Hi, I'm Dr. Amber Boler, Cardiology Fellow at Mayo Clinic, here at ACC 2018. I'm joined today by the Director of the Barbara Streisand Women's Heart Center at the Cedars-Sinai Heart Institute, Dr. Noel Bairey Merz. Thank you for joining us today.
My pleasure.
So we had a few questions about starting a women's heart center and for other institutions out there, how they would go about starting such centers that you have at Cedars-Sinai.
I think our success has been we do the tripartite academic mission of clinical care, research, and education. And we've been fortunate to be able to do that in our medical center, which is very supportive of the academic enterprise. The second thing I would say about the clinical side of that is that we've been able to take care of patients that the community physicians don't want to take care of them, or they want some help. So we have opened doors for MI with no obstructive coronary disease, MINOCA, INOCA, which is ischemia with no obstructive disease. We'll get second opinions for healed Takotsubo, healed SCAD, or even what was that? This is a funny looking angiogram. Is that a coronary aneurysm? So we definitely have had some success there. Persistent angina in the setting of open arteries can be a real frustration to the community cardiologist. Two other areas, we do heart failure with preserved ejection fraction research. So even though we don't probably do very much for these women and some men, in terms of we don't have any effective therapies. We do a lot of, I understand you don't feel well, and we do the diuretics and the beta blockade, so they do at least feel like they're being treated, where again many community cardiologists will tell them that they're fat or that they're just out of shape and they don't have a safe place to go. The last area is I am a preventive cardiologist, and we will use advanced imaging as well as better risk factor assessment, adverse pregnancy outcomes, consideration of autoimmune disease, to do a better job preventing cardiovascular disease in women and men. We're a go-to clinic for that advanced preventive assessment and treatment.
And you really spearheaded the movement for cardiovascular health in women and acknowledging the differences in cardiovascular health in women and men. What have you seen over the past 10 years as far as education of the cardiology community and just the community at large in regards to women's cardiovascular health?
Well, I follow in the footsteps of Dr. Nanette Wenger, who gave a fabulous Simon Dack lecture and really outlined the many decades of work that has now resulted in women finally dying about at the same rate of cardiovascular disease as men. We do feel like we have a lot of work left to do. Prior to 1984, women did better than men. So if that is more of the natural biology, which would make sense with our longevity, we still have quite a lot of work to do. Yes, we've worked on awareness campaigns, which have resulted now finally in 53% of women on the street know that heart disease is the leading health threat for themselves. We have done physician surveys and campaigns, and cardiologists are doing better. They're still not doing as well as they might in understanding sex and gender differences and treating for precision medicine. Which would be treat the man for things that you know, etc. If there's a difference, you might treat them differently. And we've also worked hard on policy, both within the American College of Cardiology, the American Heart Association, but at the local, state, and federal level in terms of making sure that sex and gender is included in research agendas, in clinical education of our future physician workforce. I'm very excited about the ACC's diversity campaign, which we know that teams, the cardiovascular team, we know from business, from education, that diverse teams make better decisions. So I suspect that our patient care will improve with our diversity initiative, which will be not only inclusive of all of the team members, but a realization that diversity in our patient care with personalized and precision medicine is going to improve care as well.
It's excellent advice. Do you have any advice for female fellows who are looking to follow in your footsteps, their careers in academic medicine, how to go about making a name for themselves?
That is a very good question. Of course, the standard advisement is when asked, serve. When asked to serve, sit right up at the head of the table. Don't defer. And when asked to do the work, do it. And on time. Don't do other people's work. I hear a lot of women complaining about the guys left the cath lab in a mess. They didn't read their echoes again. They still haven't rounded on patients. Okay, I'll do it. That's housekeeping. I don't think we went to medical school to be housekeepers. And I guess the last thing that I would say, we have a women's health leadership consortium that we started maybe 6-7 years ago with the idea, testing the hypothesis that if we created more endowed chairs in women's health, that there would be more endowed chairs held by women, and that it would do two things. It would promote women to more leadership within academic medicine, and that would result in policy change that would result in improved women's health. And we just submitted a progress report to a special edition of Lancet, and we have been able to go from less than 6 endowed chairs in all of North America when we started in 2013 to 36 chairs in a pretty short period of time. And so here's the take home, I guess I would say to your fellows in training. We do think that hypothesis so far is partially supported, that women's health, women's heart may be a good opportunity to lead if you're having trouble breaking the glass ceiling, and then use that to springboard to higher level things.
Great. Thank you so much. I know many of our fellows in training will really appreciate that advice.
Okay.
For more videos like this, head to youtube.com/FITsontheGO.